Well, good morning.
Good morning.
Had a little audio problem, but I think we're up and running. So this is session 2 of our series on becoming a better consumer of healthcare. And in the first session, when we talked about, we were talking about health literacy, one of the important factors was to be an engaged, informed patient. And one of the areas where I think it's particularly important to be an engaged, informed patient is thinking about your diagnosis. So if any of you that have been in the hospital or worked with the physicians, probably the greatest risk that you face is related to errors in diagnosis. And so one of the things we're going to talk about today is the types of errors that occur in diagnosis and things that as patients you'll be able to do to help minimize the harm from diagnostic errors. This is, in terms of disclosure, diagnostic errors is something I've been kind of passionate about in my own career. I've been on the board of directors for the Society for Improving Diagnosis in Medicine. This is a multidisciplinary organization that works with a variety of healthcare providers, legislators, patient advocates, legal, all to work on improving diagnosis in healthcare. I'm also the physician advisor to the Pennsylvania Patient Safety Authority. They have a center of excellence on improving diagnosis. So I'm going to start off with a patient story. This is an audio, it might be a little quiet. Hopefully you'll be able to hear it. See how it goes.
I'm Sue, and I'm a mom and a widow. My husband was really athletic. Pat was a runner. He had all kinds of aches and pains all the time. So when he started to complain about neck pain, we kind of dismissed it. But then it got to a point where he was having a hard time tolerating the pain. So we finally went to an orthopedic doctor, and they found a mass in his cervical spine. Pat had surgery. It was significant surgery. Physician came out and said it's a benign tumor, so we weren't worried. About 5 months after surgery, we learned that the tumor was back. Pat went through every kind of treatment that he could go through, but they couldn't save his life. In the hospital, we were visited by multiple physicians asking why Pat hadn't had treatment after the first surgery. Considering we were told it was a benign tumor, it didn't make sense to me. We recognized that a huge error had taken place. The final pathology from the first surgery was discovered to be malignant cancer. It never got back to us or apparently to the neurosurgeon. The kind of cancer that Pat had was treatable. Had that communication that got closed, I think my husband would be alive.
So that's one of the types of diagnostic errors that we see occur is when reports don't get communicated to other members of the healthcare team. It can lead to harm such as Sue described in her story. I've known Sue for probably about 10 years. She's kind of used her experience to really become an advocate for patient safety and diagnostic errors. And she was on the board of trustees with me in CINM. I should also point out it's not her only diagnostic error that she suffered in her family. She had a child that was also had a diagnostic error related to kernicterus, which is when you have a high bilirubin at birth and can lead to cognitive impairment if it's not diagnosed early. So she's been through quite a bit related to diagnostic errors, but has been an incredible advocate on the national front for addressing this issue around harm and diagnostic error. Point out that medical errors themselves have been around as long as medicine has been practiced. Got a lot of attention nationally back in 1999 when the Institute of Medicine put out a report to err as human on the diagnostic errors that were occurring in healthcare. And the thing that really got a lot of national attention at that was the number that said between 45,000 to 100,000 patients were died each year as a result of medical errors. And these were typically errors that were related to medication errors, patients that got the wrong medicine and suffered because of that, wrong site surgery, hospital-acquired infections. Those were the things that really got a lot of attention. And when you go back and you look at that report, the major error that was present in hospitals that caused diagnostic error, or that caused harm, was diagnostic error. That was about 17% of the errors. Subsequent to that, Lucian Leap, who was one of the authors of that study, went back and looked at some additional autopsy data and projected that there's probably about 40,000 to 80,000 hospital deaths annually as a result of diagnostic errors. That is, patients that had a condition that had the physicians known about it, could have been treated and could have been addressed, they would have had a better outcome from that. So we know from autopsy data, and it really hasn't changed over the last 50 years, that about 10 to 20% of autopsies will identify a condition that, had it been known before the patient's death, could have been addressed and treated. This has not really changed a whole lot. One of my colleagues down at Johns Hopkins, David Newman-Toker, put out a study in 2019 that really reviewed a lot of the existing data around diagnostic errors. And what they found, if you look at malpractice data, which is obviously a little biased, certain types of studies get into malpractice cases, so it's not a true cross-section of all the types of errors that occur in medicine, but about a third of medical malpractice claims are related to diagnostic errors. Many of those are things like misdiagnosis of cancer or misdiagnosis of a fracture. So they're very common. They're still very catastrophic. The most recent data we have from autopsy deaths still is about 10–15% of hospital deaths had a diagnosis identified that, had it been known at the time, could have been treatable. And it's also incredibly costly. Just in terms of errors that can be directly attributable to diagnostic errors, it's estimated that $100 billion to $250 billion per year are going to treat harm that's caused by diagnostic errors. So you think, with the significant impact of diagnostic errors, why wasn't it addressed in the original IOM report? And I think Bob Wachter, who's a hospitalist out at the University of San Francisco, put out a really nice summary on why that was the case. And one was the report itself, the IOM report, when it came out in 1999. You're telling people that 40 to 100,000 people are dying each year, you better have a solution to address it. So there was a lot of attention put on errors that were easily fixable, medication errors, making sure that the label on vials was the same, making sure that vials didn't look similar. Things around hospital-acquired infections. We're really looking at rigorous hand washing techniques and sterility in areas to reduce the harm from infection. Addressing wrong site surgeries, making sure you were working with the right patient when you're in the hospital. Those were things that you could apply standard systems approaches to and really reduce harm. So they got a lot of attention. At the time, and it's still the case, that diagnostic errors are really difficult to define and very difficult to measure. If you can't define something and you can't measure it, it's hard to really develop a change around it. So that was a problem. A couple of the other big problems are a lot of the diagnosis occurs in the outpatient setting. And when you're in the outpatient setting, particularly back in 2000, you're dealing with a very fragmented healthcare delivery system. A lot of individual practices, people that have different information systems. At that time, most physicians just had paper folders. So it's very difficult to share information and to work collaboratively to reduce diagnostic errors. One of the big reasons I think it's very difficult to treat, we'll talk a lot about that today, is that not only are there system errors, things like the infrastructure is not set up to address it, but it really is driven a lot by cognitive errors, how physicians think, which is no different from the way all humans think. But it's very difficult to change how people think to be able to address those diagnostic errors. Unlike medication errors, where if you give the wrong medication, you might find out within seconds that there's been a problem. With diagnostic errors, the identification of the harm oftentimes will occur months to years later. I'm a radiologist. If I miss a nodule on a chest x-ray, it might be that the patient doesn't come back for 2 years and find out, oh, you missed a lung cancer. So there's a long interval between the time that the error occurs and when the harm is identified. So it's very difficult to close the loop on some of these. And finally, there isn't a really good business model for reducing diagnostic errors. Right now, if you do diagnostic testing, you get paid for it, whether you were accurate or not accurate. And so there's not a large accountability for having systems really work to address the harm that's caused by diagnostic errors. So part of the work that we did at CITM was we wanted to really address this problem of diagnostic errors. And so we worked with the Institute of Medicine, at this time it's the National Academy of Medicine, to focus specifically on the harm that's caused by diagnostic errors. This is a report that came out in September of 2015, and what their conclusion was is that diagnosis, in particular the occurrence of diagnostic error, has been a large, unappreciated effort to improve the quality and safety of healthcare. The result of this inattention is significant, and the committee concluded that most people will experience at least one diagnostic error in their lifetime, and sometimes that will have devastating consequences. So again, kind of illustrates the fact that it's really hard to measure. We didn't come out with a number of 40 to 100,000 people per year, but just that it's common. Very likely all of you will at one time in your life experience a diagnostic error, and hopefully you won't be one of those which it has devastating consequences. One of the things that report did was try to build a better definition around what is a diagnostic error. And so it's really, this whole report is centered around the patient. And so for a diagnostic error, it's the failure to establish an accurate and timely explanation for the patient's health problems. What's the underlying cause that's causing your symptoms or causing your loss of function? And it's also a failure to communicate that explanation to the patient. So for example, in Sue's case, where there was a diagnosis, the pathologist knew it was a malignant tumor, but it wasn't communicated back to the patient, it wasn't communicated back to the team. That's a diagnostic error. So trying to put an explanation and definition around a diagnostic error that really focuses on what is the impact of that harm to the patient. This is a very busy slide, but one of the things I think that is important is to think about the diagnosis as a more extensive process. I think many of us think diagnosis is when we go in, we see the doctor, he asks us some questions about, tell me about your problems, when did it start, what causes it, what makes it worse, what makes it better. You do a physical exam, run a few tests, and you come up with a diagnosis. It's actually a much more extensive process than that. And this is a very busy slide, but I like to break it down into kind of 3 different processes. One occurs even before you see the doctor. And part of that might be failure to recognize your own symptoms. This is common, for example, in some patients that are having strokes. They don't even recognize the fact that they're having a stroke. And so the identification of a patient to be able to recognize that they're having a problem for which they should be seeking medical care is part of that diagnostic harm that can occur from a delayed diagnostic process. It could be that there's a delay in access to getting into healthcare. So if you live in a remote part of Potter County, for example, and you're having a stroke, there's not a lot of healthcare access that you're going to find in the nearby areas to be able to treat you in a timely fashion. And there's large portions of the U.S. in which those 2 types of geographic dispersion is going to make it difficult to access healthcare. There may be a lack of diagnostic experience or resources. There might not be a physician that's trained at diagnosis and treating strokes in your area. It could be that you don't have health insurance, or you have other reasons why you might not be able to access healthcare. So all of those contribute to the harm that can result from a delay in diagnosis. The other phase occurs after you see the doctor. A diagnosis has occurred, but has it been communicated? Again, as in Sue's case, there was a diagnosis, but that information has to get back to the appropriate people, the other members of the healthcare team, back to the patient. It might be that you have a diagnosis, you're getting treatment, but you're not getting better. that should trigger alarms that, hey, maybe the diagnosis is wrong, maybe we're treating the wrong thing, we need to go back and reassess that. Again, that closing of the loop. A lot of these types of problems are oftentimes IT related. They're related to getting communication back and forth, getting data to the right people, getting the right test results back to certain people. So IT infrastructure is really critical for this phase. I would say that the first phase I'm talking about, before you see the doctor, a lot around that is just healthcare literacy, public health measures that are important there. And then there's that middle part that we think about as diagnosis, when you're actually seeing the doctor. The questions that they ask you. Are you a good historian? Can you describe the symptoms that you're having in a way that allows the physician to understand kind of what is the problem that you're having? The physical exam, the diagnostic test that performed. And when you look at that whole process that occurs with the patient-physician relationship, a lot of the errors occur in this diagnostic testing. Either the tests aren't ordered, the tests aren't performed properly, the results from the test don't get back to the provider. That is in this portion of the diagnostic process where a large number of errors occur. You may have consultation with other physicians to try to get input on what the diagnostic process is. And then there's that integration of all that information that's necessary to come up with a diagnosis. So the key thing from this is that the process of diagnosis is not simply that 5 minutes that you're spending with the doctor. It's the whole entire process that we need to think about as far as opportunities for harms to occur. So if we think about what types of conditions are prone to diagnostic errors, there's been quite a bit of studies that have shown it really breaks down into 3 big areas. And those are oncology, in which lung cancer is the most common one for causing diagnostic error. So a missed lung nodule, for example, on a chest x-ray, or a delay in diagnosis that leads to patients presenting with lung cancer at a stage where they're less treatable. But other types of cancers that you would expect to fall into there, so breast cancer is a common one, colon cancer, not getting patients screened, for example, prostate cancer. Vascular events make up about 1/4 of the diagnostic errors. Of those, stroke is the most common. We're getting pretty good at diagnosing heart attacks. Most patients, part of that is a public awareness campaign. Most people understand when they're having a cardiac event. They typically have pain from it, they're going to get drawn, they're going to seek out symptoms. Less often the case with stroke. Oftentimes patients don't recognize that they're having a stroke. And certain types of stroke in particular are very difficult to diagnose. For example, dizziness is a common problem seen in the emergency room. About 3 to 4% of patients presenting to the emergency room are presenting because they're dizzy. The problem is there's a tiny fraction of those patients that are presenting to the ER with dizziness because they're having a stroke. And oftentimes those are younger patients. They tend to be atypical kind of strokes that occur in the back of the brain. The problem with that is that when they occur, they can be really devastating. So they occur in younger patient population. They can lead to problems in which we call it locked-in syndrome, where the brain is working fine but doesn't communicate with the rest of the body. So the only way they have to be able to communicate is by blinking their eyes. Any of you saw, get the movie that was out a couple of years ago, kind of describing that situation. But that's some of the problems around stroke. And then infection is the third of the big 3. Those sepsis is the thing that we really worry about. So sepsis is when you have a severe, overwhelming infection that can lead to loss of cardiovascular collapse and can lead to fairly rapid death if it's not diagnosed quickly. So those are the areas where harm from diagnostic error occurs most frequently. It's around cancer, vascular events, and infection, and stroke. Just recently, you may have seen this in the New York Times. David Toker's team went through and they looked at a large series of studies that were done on diagnostic errors in the emergency room, and it really reiterated that these are the big areas that we need to think about. Cancer, vascular events, and infection. Those are the ones that were typically missed, and as it relates to emergency room events, a lot of it was centered around a diagnosis of sepsis and a diagnosis of stroke. So we think, how do diagnostic errors occur? It's important to kind of break up how do they occur and what can we do about them? And I think it's important to recognize that there are some diagnostic errors that we're never going to be able to fix. We oftentimes hear about the 45-year-old that was fairly athletic, went out for a run, and died on the side of the road from a heart attack. And at autopsy has pretty significant cardiovascular disease, but never had symptoms from it. That patient had a pre-existing condition that I guess if we did a cardiac CT, we might have been able to diagnose it, but had no symptoms. There was no reason to know that that patient was at any different risk from the general population. Some patients present with very typical symptoms. For example, this can sometimes be a problem in women presenting with heart attacks. They present differently than men sometimes. Some will have less symptoms, sometimes they present more with GI type symptoms. So they have a presentation that's oftentimes can be atypical and make it difficult to diagnose. So there's going to be a certain subset of these errors that we're just never going to be able to eradicate. There's system types errors, and those errors occur when there's a problem with the infrastructure of the healthcare. Patients had previous records at an outside hospital, but they weren't available for the treating physician. There might be that the patient needs a CT scan, but that CT scan is not available. There might be that expertise is not available, or problem in communication, which we've been talking about, and that abnormal lab result that's not followed up. Those are system type problems, and we can use the same type of solutions that are used in other system type processes, like medication errors, for example, and we can reduce those. And they can be reduced, and this is where a lot of the attention is being focused, but you have to continuously monitor them over time. Make sure you're looking at those processes and making sure that they're being improved. And finally, there's cognitive errors, which are really the unique part of diagnosis, apart from diagnostic errors. And those are things about, are we thinking properly about the diagnosis? And they could be the knowledge deficit, the physician wasn't trained properly, failure to perceive. In radiology, that's our major source of errors, our perception errors. It's about 80% of the errors that occur where the finding is present on the radiograph, it's just not seen until it's pointed out, then you can't miss it. You say, how did I not see that? That's an area that we're doing a lot of research in, is trying to understand what drives some of those perception errors. And it's really related to human cognition. So those are some of the things around cognitive errors that make diagnostic errors particularly difficult to address. This was a study from back in 2005 that kind of broke them out and tried to categorize in reviewing diagnostic errors, where did these typically occur? And about 3/4 of them had a cognitive component to it. There was a problem in the way that physicians approached and thought about the problem that led to errors. So this cognitive component of diagnostic errors is a significant driver of errors, and it's also very difficult to help eradicate. So that's, I think, one of the reasons that these diagnostic errors are very difficult to address. When we think about errors, a good model, it doesn't matter whether you're talking about errors in engineering or manufacturing or any type of process, James Reason many years ago came up with this Swiss cheese model of errors, where you think about a step in the process as being a slice of Swiss cheese, and then the holes in the Swiss cheese are these latent errors. There's opportunities in any step of a process for an error to occur. If you're manufacturing a car, if you're writing code, there are these things that are built into those processes that potentially could lead to harm. But if you understand where those errors could occur, and you understand the steps of the process, what you do is you just add more and more slices of Swiss cheese in ways that hopefully that none of the holes line up, and then you're going to catch those errors at some point in the process. So you can actually use engineering approaches to address some of these system errors if you understand where the errors are going to occur, and you understand the steps in the processes, and those processes follow a clear, cohesive pattern. The problem with cognitive errors is they're really personal. There aren't as many steps. Oftentimes these are a physician working directly with the patient, so there might only be one slice of Swiss cheese here. And the other problem is those holes don't stay in the same place. The way we think is oftentimes driven by other factors. Did it happen at 4 o'clock in the afternoon and you were tired and you didn't have lunch and you're fatigued? Did it happen in a busy emergency room where there was all this other distraction occurring? Did it happen just after you saw, a patient with a similar type of condition and you were thinking about, hey, maybe this is another one of those conditions? Our brain, doesn't respond in a consistent, cohesive pattern like a machine. There are a lot of drivers that change how we think. And this makes it very difficult to try to use an engineering approach to figure out how we're going to reduce these cognitive errors. Oftentimes when we think about diagnosis, I don't know if any of you watched that show House that was on probably about 10 years ago, but they kind of view diagnosis as more of intuition. So, the doctor walks in, sees this, calls out this diagnosis that nobody else has thought about, and voila, is the correct diagnosis. And fortunately, it doesn't always happen that way. But there was a good book that came out a few years back about how doctors think, and I think one of the things that take-home message from how doctors think is that it's no different from how any of us think. It's the same human brain, and the training really doesn't address the underlying thinking process. I think one of the things that's gotten more attention now is that we have to think about how we think, and think about where are those holes in the Swiss cheese going to be. So one of the ways of thinking about this, and it's been used in a lot of areas, is this dual process theory. So you may have read Daniel Kahneman's book, Thinking Fast, Thinking Slow, or Malcolm Gladwell's book, Blink. A lot of them talked about how, as humans, we address new information. And this is very pertinent to how we think about how diagnostic errors occur. So what will typically happen is a patient presents, you say, I've never seen this before. And so you have to go into your slow thinking mode or your analytic mode, sometimes it's called type 1 processing, where you have to think about, okay, let me go back to some basics. What are the things this could be? And you're going to work through it in a very systematic process, and hopefully then over time, you would reach the diagnosis. Now, if you start seeing that pattern over and over again, suddenly you start to begin to recognize it subconsciously. And you go to a fast thinking mode. Say, patient walks in. We sometimes refer to these in medicine, and at least in radiology, as Aunt Minnie. Aunt Minnie walks in the door, and you have to think about, is it Aunt Minnie? You know Aunt Minnie. You've seen Aunt Minnie 100 times, and this is Aunt Minnie. Same type of things happen with, in the way physicians make diagnoses. There's been studies, for example, in my area of radiology, where typically a radiologist shown a chest x-ray will identify the finding in about 200 milliseconds. They don't have time to even think about it, but something catches their eye, subconsciously they recognize where it is. And so these kind of looking at how eye patterns work and how those things are recognized is just inherently built into our subconscious, that we have developed these heuristics where we recognize those patterns very quickly and they occur subconsciously when we make a diagnosis. Just to give an example on this, when we were in Hawaii a few years ago, there was this strange bird that appeared on the table next to us, and I've never seen this bird before. I have no idea what this bird is. But looking at it, I said, well, so I had to use my slow thinking process. I said, it kind of looks like a cardinal. It's got a head like a cardinal, it's got a beak like a cardinal. I bet it's some type of cardinal. And then I pull out my iPhone, and I pull out my bird thing. I said, okay, tell me birds that look like cardinals on here. And it was a red-crested cardinal. Well, pretty soon you start seeing these birds all over the place, and it didn't matter where they were. I developed the ability to, as soon as I saw that bird, oh yeah, this is a red-crested cardinal. And that's just an example about kind of how our day-to-day pattern. All of us use this same approach to address things and patterns that we don't recognize. And the human brain is very adept at identifying patterns. We are basically pattern recognizing machines, and that can be a good thing. It allows us then to be able to take these things that occur on a regular process, and they occur now in a subconscious process. And from an evolutionary standpoint, it made a lot of sense. If you were able to recognize, where you were in the subtle rustling of the bush, you recognized threats earlier than other things, and you were able to identify them and respond to them faster. So we became very adept at recognizing these patterns. And it's our preferred way of thinking. Whenever possible, we like to think fast. If you look at studies, physiologic studies, this type of thinking uses a lot less glucose. We use a lot less energy to be able to do this. And so it is our default mode. When possible, we want to be thinking fast. So we're going to do a little test here on whether you're thinking fast or thinking slow. So here's the test. You have a bat and a ball that costs $1.10 in total. The bat costs $1 more than the ball. How much does the ball cost? All right, so if you were thinking fast, we call that intuitive processing. You might have said, ball costs 10 cents and $1 for the bat. Because you would think, you're kind of primed by the fact that dollars in the message. But if you actually sit down and do the math, you would realize, no, that's not the case, because the bat costs 90 cents more than the ball. If you started to go through it more analytically, you would recognize that the bat has to be $1.05 and the ball has to be 5 cents. So you're just kind of recognizing kind of what are some of the cues. If you were just kind of thinking intuitively, you may have jumped to the wrong answer. And that is the problem with intuitive processing as it relates to diagnostic errors, is that it can occur very quickly. And it's the preferred way we want to think about diagnosis. It oftentimes is correct in well-trained physicians, but it's prone to certain types of biases. So when we think about how physicians become good diagnosticians, the trainee will start off being very time-consuming. They have to think very slow through every process. And most of the time they're going to be wrong. So they're not very good at it, and it takes a lot of mental energy. But over time, they start seeing more and more patterns after years of training. And they develop these shortcuts, we call them heuristics, these mental heuristics, these fast tracks to be able to get to diagnosis. And eventually they develop expertise in which they're able to use their intuitive processes, and they become very accurate and reliable in these processes. And that's kind of the process by which all of us become experts in certain types of cognitive processes. The problem, as I touched on, though, is that if we don't constantly look at these heuristics, we're prone to cognitive biases. And these are where our adaptive thinking really can lead us to sources of error. I'll just point out that there's been over 100 different cognitive biases that have been identified that contribute to diagnostic errors, but just a couple of the important ones. One is anchoring bias, and here's an example of anchoring bias. So you have a 65-year-old woman, she has known osteoporosis, she presented to her family practice doctor after a day of vigorous gardening. They got an x-ray, it showed a compression fracture. So this is where the vertebral body is like kind of a Lego, where the Lego gets squished almost like a piece of cheese. And osteoporosis is a weakening of the bone. This is a common fracture that we would see, particularly in elderly women, because of weakening of the bones. Kind of a natural thing is that we knew the patient had osteoporosis, they were doing an activity in which they were standing, so quickly kind of jumps to the fact that this is likely an osteoporotic compression fracture. But by doing that, doesn't consider other potential opportunities. So in this case, it turned out that that compression fracture was due to the fact that there was a metastasis in that vertebral body, and the patient had metastatic carcinoma. So thinking of anchoring on osteoporosis, rather than saying, let's think about what else could this be, is one form of driver of diagnostic error. Another one is availability bias, and this can occur a lot. There's an example of this. Is a 22-year-old student from college, came home on winter vacation, was developing symptoms of a cold. She went to see her family practice doc. It was right smack in the middle of flu season. Everybody else that's been in the office that day had flu. It's happening right now. We're seeing a big epidemic of flu. So the physician thinks this is most likely flu. You're going to treat your symptoms. Get plenty of rest, drink lots of fluids, stay at home, stay around other people. Or her symptoms were getting worse and worse, and came back to the ED 3 days later, and she had a community-acquired bacterial pneumonia, which we treated differently. And so in this case, that availability, the fact that all the other patients that I'm seeing this time have this condition, this is probably going to be the same type of condition as what we call availability bias. We used to joke that we see this a lot. The patient, if you come onto a shift and the first patient that presents to the emergency room has a pulmonary embolism, where the blood clot goes to the chest, you can be guaranteed that every other patient that shows up that night that has any form of chest pain or a cough is going to get a CT for pulmonary embolism. It's just going to happen. You're going to be very busy. And it's kind of like that old thing, you know, if you've been using a hammer all day to pound nails, the screws pops up and you're probably going to hit the screw with a hammer as well. So that's availability bias. Then another one is attribution bias, where we kind of use kind of our own pre-existing perceptions around things to attribute symptoms to a certain condition. So example here would be an intoxicated homeless man. He presents with a large ulcer on the bottom of his foot. He's unclean, he's unkempt, he doesn't have shoes. The physician assistant that's seeing him assumes that this ulcer is probably due to the fact he doesn't have shoes. He's walking around, injured his foot, you know, got infected, wasn't able to heal. And so it's going to be difficult to treat unless we get him shoes and get him, you know, ability to get that wound improved, which is probably the case. But it turns out that he's not intoxicated, but he's having a diabetic episode where it's affecting his cognition and contributing to his foot ulcer. So I mean, we see this a lot, for example, in patients that have pre-existing mental illnesses. That oftentimes we attribute their symptoms to their mental illness and don't think about that. You know, people with mental illnesses can also present with strokes and heart attacks and other conditions. So that attribution bias can sometimes limit the scope in which physicians are thinking about the types of errors that can occur. So one of the things that leads to bias, and it's particularly problematic in diagnostic errors, is this incomplete feedback loop. So the way it should work is that you see the patient, you make a diagnosis. Say you're in urgent care, you make a diagnosis. The patient, it turns out that you were wrong. You went somewhere else, got a diagnosis. Well, we'll come back, you find out that you were wrong, and then you say, hey, maybe the way I thought about that case was wrong, or I should have done things differently to address that. The problem is that never occurs, or rarely occurs. And oftentimes the patients seen at the urgent care, ends up going to another urgent care somewhere else. It's very fragmented, that diagnostic process. So without that reinforcement, you don't get that feedback. And so that lack of feedback oftentimes turns into positive reinforcement. So I find this a lot when I go around and I talk to other healthcare institutions. And it's like, do you have a problem with diagnostic error in your organization? Oh no, we don't, but those guys down the street, they're really having a problem. Because we've seen a lot of patients there that have come to us that have had this problem that they missed. So it is an inherently problem. We talked about the long feedback loop. That lack of feedback on your performance oftentimes can really accentuate the fact that you're not evaluating your heuristics. You're not thinking about how you think, and you're not aware of when those heuristics are causing problems. So the way we should think about this process of become an expert is that, yeah, you're the expert, but you should continuously be monitoring those heuristics, self-reflecting on them, identifying where there's gaps, where there's holes, where there's things that you need to be able to address, and constantly be modifying those heuristics so that there's a process of improvement. So that's kind of one of the goals that we'd like to build into. So we talked about, kind of diagnostic errors, the fact that they're very common, that they're difficult to treat. So what can you as a patient do to reduce your risk of diagnostic error? And I think a couple. One refers back to what we talked about last time. We talked about being an engaged, informed patient. And that's so important. Be very familiar with your health care. Understand what medications you're taking. Understand your prior medical conditions, what surgeries you've had, what conditions you've been treated for. Know the medical history of your close relatives. So a lot of times our risk for certain types of diseases are genetic. So understanding what other diseases your family might have been prone to is really important to be able to have that. You should write it down, you should have a record of that, so anytime you go to see a new physician, you have able to transfer that information. One of the things that's really important is to be a good communicator of your symptoms and your condition. Understand kind of when did your symptoms start. And sometimes just writing notes to yourself, really thinking carefully about this is important. Because you oftentimes, when you're first going in to see the physician, you might only have about 5 minutes to communicate. And how you present that will oftentimes frame how the physician's kind of seeing your problem, seeing your case. So if you're unable to communicate it well, it's going to be very difficult for the physician then to understand what that process is. So think about when your symptoms started. Have you ever had similar symptoms? Is this a problem that's kind of always been there and you're getting these intermittent episodes when it flares up? Did anybody else in your family or who you're living with have similar symptoms? That might indicate dealing more with an infectious type process. How have the symptoms changed over time? Are they getting worse? Are they getting better? They've been changing very slowly, haven't changed much at all. Things that make your symptoms worse or things that make them better. All of that is very useful information that you should be writing down. If you go to the CITM website, I encourage you to go visit this website because there's a lot of useful information on there. But there is a patient toolkit for diagnosis. It's basically a 5-6 page document that you can write a lot of this down. This is one of the downloads they have for being able to describe your symptoms that you're having, if you're having localized pain. That kind of helps kind of formulate your thinking about that process and can help make you a better communicator of your problems. A couple other things I think is really important is you can be the advocate for metacognition and address some of those biases. So one of the things that's always important is, what else could this be? You think it's this, but with my symptoms, are there other things that we need to be thinking about? Again, kind of getting around that anchoring bias that could occur, help to drive that. What tests are used for that diagnosis? And what is the reliability of those tests? We've done these tests that they've come back, but what is the chance that that test could be wrong in this condition that you're thinking about? Or is there another test that's going to be more accurate on this? So understanding how, asking about the types of tests that are used in your diagnosis are important. One of the things that's important is understanding what is the outcome of that diagnosis. If you have this diagnosis and this diagnosis is correct, what should I expect to be experiencing over the next couple of days or next couple of weeks? Because if that's not occurring, could it mean that the diagnosis is wrong? And is there something else I should be looking for that might indicate there's something else happening? And who do I communicate back to let people know that this is happening? One of the things I think is really important, and I think Sue's case really illustrated that, is follow up on your test results. You should have a list of, here are the tests that I've had, whether it be an x-ray or an ECG or a lab test, or a pulmonary function test, or whatever test that you're having, write them down. Know when and where they were performed, and before you go, ask, how am I going to get these results back? Typically, they'll be sent back to your primary care provider or the ordering physician, and they will communicate them to you. But you want to understand how those results are going to get back to you, and understand kind of when would I expect results. And then if you haven't heard back, follow up on it. Call somebody and find out, what was the outcome of those results. Sometimes you can do that on your patient portal. Those of you that have access to a patient portal, I really recommend using that. But you don't want to assume that no news is good news, because that's when gaps in care happen. That's when we see problems. So making sure that you're following up on those results. In Pennsylvania, we had something called Act 112, which was an act that was put into place about 2 years ago for radiology reports that if there's something there that occurred that's unexpected or requires follow-up within 3 months, a letter goes directly to the patients. And Pennsylvania was the first state to enact that act. And what it's meant to do was to really make sure that patients are following up on these results, that they're not assuming that the fact that I haven't heard anything is good that happened, because there's been multiple episodes of problems like this that fell through. Kind of the case that triggered Act 112 was, I think it was the basis for some rock band that was up there, fairly famous from the 70s, I'm blanking on who it was, that had a missed lung cancer that came back 3 years later, had a chest x-ray that had a finding on it that was reported as being abnormal, but would never found out about it. And that kind of was one of the triggering events, but it's a common problem that we have to address. And so this law was put into place to try to address this. I think unfortunately what happens oftentimes is patients get these letters and throw them away, or assume that, my doctor would have called me if it's a problem, and he didn't call me, so it must not be a problem. So I think without good patient education around it is not a very effective law. The most important thing that you can do is have patients be good advocates for their care. All right, so that's a couple of overview of diagnostic errors. Just a couple take-home points. One is, I think, one thing I always tell people, diagnosis is hard. It's probably the hardest part of medicine. If we get the diagnosis right, the rest of it kind of follows. We have the treatments, we know how to administer the treatments, and that tends to occur pretty well. Not that that's not difficult, but if you don't get the diagnosis right, the rest of it becomes really challenging. Diagnostic errors are the most common form of medical error, and they can result in significant harm when they occur. Talk a little bit about why they're so challenging. It can be difficult to fix. That cognitive component is a significant part of it. Many of the errors are caused by the way physicians think. As I pointed out, it's no different from the way any of us think. And those same things that make humans prone to certain types of biases can contribute to diagnostic errors. Probably the most important thing that you can do as a patient to reduce the harm from diagnostic errors is to be engaged and well informed, because you can be the most important advocate in reducing harm from your diagnostic error. All right. Any questions? Hopefully it's scary.
It's kind of a downer to listen to this, but are things improving over the last 20 years? I mean, how do you judge improvement in this area?
I would say it's really challenging. I think improvement in that we're making people more aware of this. So I think that was the first thing. I think for a while people, there was so much attention put on other forms of medical errors that people weren't aware of the diagnostic errors. There's been some good improvement, I think, around in some of the system errors. For example, the interconnectivity of healthcare information. Really important to make sure that information is communicated back and forth. That's been improved. There's a lot of additional tools now around closed loop, following up abnormal test results. So where a test gets done, it gets logged on the list, and make sure that everybody that's supposed to get informed for that, there's a process for making sure that that occurs. Those are some areas where we've had significant improvement. I think we've done a lot of work around training. For example, I have quite a few courses and curriculum on these cognitive types of errors for students. So we're making people aware of it. The problem with that is, even if you're aware of it, you're going to continue to make those types of errors. It's just innately human. That's how we work. So one of the areas that we're really focusing on is more human factors engineering, how we interact with this technology in a way to say, you are going to have these cognitive errors, but can we help to predict when you're going to have them? And so in our lab, we're doing quite a bit of research around that as it relates to perception errors, for example. And we know there are certain things that can make radiologists more prone to making these types of errors. And so now we're trying to study what's happening in the brain when they're doing that thinking, doing that processing, to be able to make triggers pop up. Similar to the way your car, you drive down the road now, and it can kind of predict, you're drowsy. I can tell because you're hitting the brake every 15 seconds and you're hitting the sideline like once every 30 seconds. You need to stop and get a cup of coffee. And so one of the things we're looking at, can we develop a different, similar type of approach? We're looking at the activity in your prefrontal cortex, and you're undergoing this state, we call it mind wandering. You've all experienced it when you drove. You drive to work, you can't remember if you stopped at that stop sign, or how did I get here? You got there, obviously did well, but you weren't thinking about it. Or you're reading a boring novel and you've flipped 10 pages, and you say, I cannot remember anything about this story, but I've been reading for the last 20 minutes. That's mind wandering. We think that happens to physicians as well, particularly when they're in a very challenging, drained cognitive state. And so we're developing techniques to be able to kind of look at when that happens in the brain and be able to say, hey, you're mind wandering. Snap out of it, go get a cup of coffee, and then come back when you can be more focused. So those are some of the areas where I think we're making some real progress. I would say as far as the overall harm from it, certain areas we've done much better. I mentioned, for example, heart attacks. A lot of progress in there. I think that's a diagnosis now that's not often missed. It's identified quickly. Patients, we've done a good job of informing patients. Patients are more aware of it. They're seeking treatment earlier. They're getting recognized. There's a process in place for doing it. there's progress that's been made there. Same thing around sepsis. I think we've made some progress there. Certain subcategories of stroke are now getting a lot of attention. So I'd say we are moving in the right direction, but there's still a lot of opportunity for improvement. Yes?
How much does what you as a patient tell the doctor affect the way he thinks? As an example, the lady who was gardening, and she went in with the back pain. She said, I was gardening, so the doctor immediately focused on that. So if she had gone in and said, I have back pain, and this is the symptoms, without saying, so can you sometimes give the doctor too much information?
Well, I think that example is really good, because for example, if she had come in and said, I want you to know, I had breast cancer 5 years ago. I've been having this achy, dull, achy back pain now. And boy, yesterday I was gardening and something got a lot worse. That frames it in an entirely different context than, oh, I forgot to tell you I did have breast cancer 5 years ago, and I've been, really active. And yesterday I was outside, I overdid a little bit. Now I have back pain. The doctor's going to think about those problems in a very different fashion.
Okay, then if you told the doctor, he said, this is what your problem is, and it continues, how long do you wait? Till you call them back and say, this is just not getting better?
No, that's important, and that's one of the things I think you need to ask the physician, okay? What should I expect? If we're thinking this is a compression fracture, how long should I expect my symptoms to last? What should happen if they're getting worse? For example, what he might tell you is, you start having neurologic symptoms. You say, my left leg is getting numb now. That's not typical for a normal compression fracture. We need to be thinking about something else here. If we're thinking about, if you start getting pain in another location, my back hurts, oh, but by the way, my hip hurts, and that's a different process now. So I think it's really important for whatever your condition that you have, say, okay, if this is the diagnosis that I'm having, what should I expect over the next course, the next days, weeks, or so? And if that's not getting better, or things are getting worse, or I'm starting to experience something else, what should be the things that I need to be thinking about? Because it might be that there's something else happening here. But I think to your point there, making sure that you're kind of going through, hey, here's all the conditions that I've had on there, and making sure that, like for example, if you've gone into an urgent care, they don't have a record of the fact that you've had breast cancer. They might not know that at all, and they're very likely going to say, you're at an urgent care. This is a back strain. They probably wouldn't even get an X-ray. So it's going to be very different where you see your care. So that's why you kind of have to be your own walking advocate for some of these. Jack?
Yeah, you're sort of touching on my question. If let's say your family doctor is in the Penn State system, and you go out of system, whether it be urgent care or something else, some other system, normally the other system wants to know your family doctor, and that's part of the paperwork you fill out. Are they taking responsibility of getting this medical record back into your system?
And typically that's why they want to have it, because they'll often have a letter, or here's the treatment that you had, the condition, because they're going to be anticipating that that's where you're going to get follow-up care. So we do that. For example, we almost become an urgent care sometimes, at the medical center, because we have a lot of patients visiting from out of state. So they come to Hershey Park and they have some injury or something. They get seen at the ED, and lo and behold, they might come in with banged against the side of a roller coaster. I have some chest pain. And so we do a chest x-ray, and you've got a rib fracture. You also have a nodule in your right upper lobe that needs to get followed. And they're from someplace in northern Ohio. And so who's going to follow up on this? So what we have done is that we follow up with the patient and say, there is, they get a letter from us, and they say, there's a condition that we've found that needs follow-up. Who is your primary care provider? We're going to send them a copy of the records and the report, and then you ought to be closing the loop with that person. And then what we found is just sending a letter doesn't work. That we actually have a nurse that calls them. They'll call them, we sent you a letter. Did you get it 2 weeks ago? Did you follow up with your physician? No. Okay, who is your physician? We'll try to follow up with them. If they don't have a physician, we try to find them a physician. So those are, you have to be that aggressive in following up these.
And on that same question then, how about medication? If somebody off your system prescribes something, isn't there like a medical information bureau or somewhere where, are they relying just on the patient to say what their medication is, or is there another way of doing it?
Yeah, no, some of it is certainly for, controlled substances. That goes up to a statewide database. So you can
Okay.
look on and say, hey, patients have received a fentanyl patch from Dr. X and something else from Dr. Y, and, so they track that fairly closely. Some of the other ones, they don't track as closely. And that can be a problem because you find out that they've got 4 different prescriptions for the same medication sometimes. And so what we typically would do then is called medicine reconciliation. Is here's all the medicines that we say you're taking. Does that match what you're taking? And they bring in a bag and say, no, here's what I'm taking. Okay. But that process of doing exactly that, it typically does fall on the patient and the provider to be able to kind of work through and say, here's what we have a record of. But to your point, oftentimes there's other things that are happening there. It's not just medicine. Sometimes it might be supplements and other things that can interfere with medications. That could be a problem.
Following up on that, you go to 6 doctors. 6 doctors give you 7 different prescriptions, and you're dutifully taking them. Who evaluates the interaction of those medications? Who's responsible?
That's important. I would say it's typically going to be your primary care physician that you're seeing. This is a big problem a lot of times in our geriatric population because they can be very sensitive to medications. They often have what we call polypharmacy, where you're taking those multiple medications, and they have certain drug-drug interactions. So it will oftentimes be the primary care physician working with a pharmacist. So a lot of our rounds now, for example, it happens a lot when you're coming in as an inpatient. That's one of the times that gets addressed. So here's all the medications that we have, and the pharmacist looking at, hey, this medication here is going to interfere with this medication. And so there's going to be this drug interaction that otherwise any one individual physician might not have recognized that they were on that. So we try to, that's why it's important to have a primary care physician, somebody who's overseeing the entirety of your care. As we get more and more fractionated care, that becomes more and more challenging.
And because of that fast thinking, would there be merit to consider flipping primary care physicians regularly to get them fresh eyes and to erase all those prejudices they have about me?
I would say that typically happens anyway because
Okay.
oftentimes it can be more challenging to see the same physician on a regular basis. A lot of times that bias that is very situational. So when you're thinking about the anchoring bias on there, it's oftentimes that episode of care. Now what I would say that you can do on there is think about, and we've always said I've had this condition on here. I'm not getting any better, I'm not getting any worse. We still think that's the condition. And I think those are kind of things where as a patient you can you might say, should I see a specialist or something? Should I have somebody else that's kind of looking at this because this is not getting any better or it's getting worse. And I think those are areas where maybe not necessarily changing your primary care provider, but asking what else could this be? What other resources maybe should be brought in to reevaluate that condition?
Do radiologists have patients?
We not usually. We do with interventional radiology, where we're doing procedures, but they're very short. They're more like your relationship with a surgeon. We're here, we do a procedure, and then your care gets transferred back to somebody else. I get calls from people that say, yeah, I'm your physician. I would say the other one is in mammography, where mammographers, we've taken kind of ownership around the breast care process, the diagnosis and getting you plugged into. So that's although we have patients, we work in a very multidisciplinary team.
So have there have been changes in medical education to teach, medical professionals or to encourage medical professionals to value input from their patients?
Big push for that. I would say in the past, no, that's a big push now. And for example, this talk that I give here, I give to our medical students all the time. And, talking about how kind of, making sure that your patients are advocates for their care around healthcare literacy, making sure that we talked a little bit about it in our first episode, about things at a national level are saying healthcare organizations have to do to make better advocates of their patients, to make them more literate about their problems, because their input is so important on their outcome. So there's a huge push on that side of it. Now, whether we're doing it well, I think it's a challenge. Because I think what happens is in a busy time, we go back to medical speak. We think we're doing a great job. I've said exactly what's listed in this thing, but we don't ask the patient, did you understand what I just said? Talk back to me and tell me what you heard so that I understand that you and I are on the same page. Those are, I think, some of the more direct process things that we're really trying to teach now. A lot of them are just around basic communication. Charlie.
From a couple things from the data side of things, whenever I go to a different doctor, they always bring up the what medications are you on, right? That question happens all the time.
Yep.
That having been said, it flags me that they haven't looked at any of the medical records, and part of the problem there is the systems don't interconnect.
Yep.
And I don't know. I mean, that seems like an obvious. The systems ought to interconnect so that I understand the need for the question. That having been said, it also reflects the fact that they have no clue.
Yeah, I'd say it's two things. One is that the interconnectivity, although getting better, is not reliable enough that you say, I'm going to trust what's here.
Yeah.
So as a physician, I'm always going to ask, because it's like,
Yeah.
some of the points come up here. Did you see another physician here that gave you another medication that I don't have record of there? So there's always going to be some of that checking on there, which I think is going to be a key part of it. Part of it is that from just a process standpoint, that's one of the steps that every time you're in there, we're going to ask you those questions just to verify it. There is, I think, a real push more towards interconnectivity up there. In some of the ways, like the different EMRs that don't interface, just from a basic IT standpoint, you put your heart rate measurements in this domain and we put it in this domain, and there's no way. We went through and we looked at blood pressure in our own EMR. It was logged in like 14, it was almost like 140 different data entry points. And so, okay, how are you ever going to consolidate this data? So somebody has to go through and be able to say, here's how blood pressure is going to be captured in the EMR on everybody's EMR, so that it'll communicate back and forth. The EMRs were never designed to have interconnectivity, and kind of the push that happened in the early 2010s was driving some of that. And we're making progress, but boy, there's still a long way to go. Your Apple Watch has probably more connectivity with your EMR than Cerner has with Epic, for example.
The other thing, I mean, the importance to care is communication between doctor and patient. And that having been said, what the data world has created this thing called an internet, where you've got patients that are coming in with very firm ideas of what they've got. And then it turns into who's got the most dominant character as to who's going to win, how that prejudice is perceived. And I don't see any way to clean that up.
Now, we talked about a little bit before, Dr. Google, Dr. Facebook.
Yeah.
Yeah, that's a real problem, because anchoring a bias can occur two ways. Hey, I've been on the internet, searching Google, this is what I have.
Yeah.
And then you spend half of the appointment time saying, no, here's why you don't have that. Dengue fever doesn't happen in central Pennsylvania. We've been to Florida lately because it happens there now. But those are kind of things that we have to, that can be problematic for, so, I think we're all aware of kind of the impact of social media and other things on driving certain biases. It does impact healthcare. You know, people doing that type of work. Yep.
But doesn't the doctor also have a problem admitting he may have made a mistake?
Oh, absolutely. Particularly around diagnoses.
Yeah, that's what I'm talking about.
It's one thing to be able to say, oh, the medication, system errors, we can say, yeah, there's a fault. We knew this hole in the Swiss cheese was there, it happened, that's gonna happen. As soon as you say you made a diagnostic error, you attack the art of medicine. That's probably when I go around and I talk to other healthcare organizations, that's the biggest thing I face, is that a diagnostic error occurs, typical response is the physician takes it incredibly personally.
Exactly.
They say, it happened, it was unique to this problem. They said, why do I want to share it with anybody else? They're not going to learn anything useful from it. And so that's not communicated. It's not standardized in a way that you say, yeah, you made it, and we've seen 6 other people make exactly the same mistake over the last month. Maybe there's something here that we need to think more systems, take a more systematic approach to, but that's a huge problem.
Yeah,
It's tough to address.
Because I think, I know my defenses go up if I'm accused of anything, or if
Yeah.
I'm corrected on something. I go, well, I said that because, you become very defensive.
Yeah,
And
no,
I think that's.
you attack the way
normal.
somebody thinks. It's a personal,
Yeah,
very personal. Jim?
Does that stuff get tracked by somebody?
Not to the way it should. For example, the Pennsylvania Patient Safety Authority I mentioned, kind of part of, any type of patient harm event gets a report submitted to it. You know, and so then there's a whole algorithm. Okay, this is a medication error. This is an infection. We tried to look at, you know, what do we have for diagnostic errors, and we have very little hierarchy to be able to. Hey, this was a cognitive error. So that's one of the things that we're working on, is saying we want you to submit these types of errors. We want to be able to track them. We want to be able to find out what are some common themes that we're seeing, so that we can start to fix them. And we are good 20 years behind other types of errors that are processed and collected, and you know, there's action items that are going to be addressed to fix those. But diagnostic errors haven't got to that point yet.
question.
Yeah.
In the last 2 years, we've been faced with COVID. We have almost nobody had flu. Almost nobody had some of these other problems. Is that the same symptom of what you're saying, where we all had runny noses, we had a slight fever, we had a cough? Oh, you have this.
Well, this year we're back to having flu and
Yeah, now we got
because we're not wearing masks. But I think, you know, a lot of the things that we did to reduce the spread of COVID were very effective at reducing the spread of all the other.
Oh, absolutely.
So it wasn't, I think, that we were necessarily missing the flu. Some of it, I'm sure people had, because we were before we had testing for COVID. You know, there were probably people coming with other respiratory tract infections that weren't necessarily COVID that got back to them. But I think what we saw there was probably more related to, you know, the public health measures that were put in place. It did, I would say COVID had a big effect on diagnostic errors, in that people were reluctant to seek out healthcare for certain types of conditions. I'm having a stroke, but by God, I'm not going into the ER with COVID. You know?
Yeah. On this same line, you talked about wearing masks again. I can remember in the 70s when I was in Asia, anybody that had a cold or a sniffle wore a mask.
Yeah.
No questions,
Yeah.
they just did it.
Became non-common.
And we find it very offensive, the thought of wearing a mask.
No, it's pretty effective. I think if you look at, you know, the impact that we had on influenza the last 2 flu seasons, almost non-existent. I'd say before COVID, you know, this time of year we'd have 5 or 6 people on heart bypass, you know, ECMO for flu. You know, it was a serious condition. We haven't seen it.
I have a follow-up about this Act 112, I think you
Yeah.
said. So I've been in the emergency room, they did, you know, CAT scans, and they found 4 things. And now, will a letter come in 6 months say, did you?
No.
I got a phone call, you know, or what's gonna happen?
So
Nothing?
Act 112 excludes things that happen in the ER, which to me, I like when I was talking to advocates for that, I say, that's where most of these happen.
Yeah. Oh.
It was really only the outpatient setting. So it didn't include the ER, partly because the volume of work that would need to be done is tough. And it was put in without a thought of the infrastructure. So I worked with, got to know the state legislator that put this in. I said, you know, the idea was great. The implementation, I said, here's some of the problems. One is that letters in of themselves do nothing. Two is that we haven't captured the big areas where there's people that fall through the cracks, ER being the main one. Three is we haven't really defined, kind of, you said like this needs to be followed up in 3 months. And that's, you know, somewhat arbitrary, that we actually need to have, you know, more specific things around what are the harms we're trying to reduce. And rather than make it like that prescriptive, allow organizations, here's what we're trying to achieve, figure out how to do it. You know, rather than telling organizations how to do it, you know, say, here's the problem that we're having. Because we had already been working on that, because particularly I mentioned the stuff that the problems we have in the ER, you know, and so we had a process in place. And so we were really trying to push it, say, get away from more prescriptive type things. Let's focus on where the problems are. And say, how are we going to develop a system to be able to make sure that these loops get closed? Yes.
Excuse me, I haven't talked much today. Are we at risk for increasing anchor bias with electronic medical records?
It's a good, I mean, I think you do have, the problem you have is that anchoring bias oftentimes will happen because you've seen everybody's previous note there, you know what their thinking was, and that's where you're gonna start from. So I'd say in some regards, yes. There's been some opportunities though to get around it. For example, it could come in and say, here's the patient's symptoms, and now there are these kind of like symptom, you know, pretty good AI algorithms that say, here are the symptoms, I can pull the demographics from this patient, I can tell you in this area I'm gonna go out and look at the CDC data and tell you here's kind of what the infectious disease are, and say, here's 5 things you ought to be thinking about. So in some ways, there's opportunities to reduce the anchoring bias. And they're getting some pretty good tools there that aggregate data from multiple areas on a very timely basis, particularly around some of the infectious disease things, where you can say, hey, in your zip code, here are the 3 most common transmittable diseases that we're seeing. Here's the age group that we're seeing them in. You know, all of this can start to populate, and you can actually get a differential diagnosis that's kind of pre-populated even before you go in to see the patient, based on the information. So those are, in many ways, I think there's a lot of opportunity in electronic medical record.
Would the bias on that be dependent on the reporting system? So that
Yeah.
our zip code has a better reporting system than, say, Perry County?
Oh, it is. It's always going to depend on what your data sources are.
Yeah.
But at least there's an infrastructure in place now that's starting to do that type of work. So,
Thank you, Ken.
oh, sure.
Yeah, I was golfing together.
Okay, I'm drawing a blank at the moment.
I said to Ken, I just played golf.
From Presbyterian. Gave me her, she goes and she's a professor, was the town hall.
He felt good about it.
And this.
I didn't get it.
Yeah, this one.
I